All right. So first case is pretty quick, but something to always pay attention to. So this was a patient, came in with cardiac arrest and had some cardiogenic shock. And you can see he's got an ICD in already, a PIC. And then this is the marker of an intra-aortic balloon pump. And it's in a reasonable position. I like it typically right below the what we call the arch on the radiograph, and you can usually see it because of the calcium. So that's a good place for it. If it's too low, because these are long balloons, you run the risk of occluding a visceral vessel. And of course, if it's too high, you run the risk of being up in the neck. And this is actually, I haven't seen that happen very often, but we noticed on this one that the marker is actually way here above the aortic arch, so it's probably in the left subclavian artery. And you can see there's the inferior marker. So it got moved up a little too far, and so that you can occlude the subclavian, or if you get farther along the carotid, you can also cause a dissection. And if you're too low, not only can you cause visceral problems, you can also make these less effective because they are counterpulsation balloons. So they're hard to see when you don't know they're there, because we typically only see the little metallic portion. It kind of looks like a clip, but if you look at them, they're just straight little metal things like that. So a malpositioned balloon pump, and they can pull it back.
Jeff,
Yeah.
I think that this one was probably placed from the left subclavian, from the left axillary, because there's a sheath in that left axillary artery. So I think this is an upside down one, and I think that we're actually seeing the proximal marker here above the aortic arch. You see that that sheath in the left axillary artery?
Yeah.
So this is what our cases look like when I call these upside down.
Mm-hmm.
They're left axillary, and that seems to be, in many cases, the preferred route. I think it's easier to take care of the patient. The patient's more ambulatory than if he has something stuck into his groin.
Right.
They like to do this, and that means that instead of telling them to pull it back, you need to tell them to advance it when it's in this position here.
Interesting. I think this is one of the first ones I've seen here go in this route.
Yeah, and it's possible that I'm wrong and that sheath is there for some other reason, but that looks exactly like the sort of introducer that they use for the intra-aortic balloon.
It's just interesting. It doesn't seem to be hooked up to anything.
Yeah. Well, it's a good point, and maybe they're planning to do that. So, what's the giveaway is to have the little faint part of the tip that's beyond the bright metallic part.
Mm-hmm.
Sometimes you can tell. Do your intra-aortic balloons have that faint extension beyond the metal?
I don't think so. I think this is what we usually see. I don't recall ever seeing one.
Even at the tip. Okay.
Yeah. And the ones I've seen on CT have always come from below.
Okay.
But I could be wrong. Well, thanks for pointing that out. That's a good observation. This is a fun case you'll like, David. So this was a consult off of an abdominal CT, and you can see there's this mass in the right lower lobe. It's got these kind of cystic spaces. It's got some dystrophic calcifications in it. There's some pleural stuff going around it there as well. If we go to the lung windows, you can see there's just a little bit of crud down there. But what's kind of cool is if you follow it all the way down, you see that there's this vessel right here. And this vessel has some atherosclerosis, and it continues all the way down. Crosses, interesting, it crosses right through the diaphragm there. There's a little channel for it. And then it arises right off the SMA right there. So systemic arterial supply, and with this kind of socked in area with cystic stuff, kind of tubular and some discrete margins, it would be consistent with a sequestration. So I went back and found an old CT that's not that far off, maybe a couple years. And lo and behold, we do have a congenital lesion down there. So you'll notice it becomes hypovascular. And then we see kind of an absence of airways. And then we see a dilated bronchus, a couple of them. They all communicate together. And then but they don't hook up to anything. And then there's that big artery going down there. So I think this is a hybrid lesion of, I think it's a sequestration with bronchial atresia, which is not all that uncommon. It's not uncommon to see bronchial atresia in CPAMs and sequestrations, but I'm presuming what happened is it got infected and then it's all socked in. So I pulled some old radiographs. This was like about 2.5 years ago, and clearly wasn't a big mass back then there, but it wasn't quite normal. Let's see if I can find the lateral for that one. Here's the lateral. Hard to say if there's much there, but it clearly wasn't a socked-in lesion. So I'm guessing in the last couple of years this thing got infected. So the question is what do you do with it if the patient's asymptomatic from it? It's already been infected. Do you just leave it alone, or do you go and try to resect this thing? Here it is here. I'd be inclined almost to want to leave it alone at this point, unless if it's not causing any problems. But yeah, so having that systemic artery is kind of cool. And going back, you can kind of see what this looked like before. But hybrid lesions are much more common, I think, than we think. We often teach them as individual entities, but looking back at most of the congenital lesions I've seen, they often have bronchial atresia in them. I'd say more often than not. All right. David, you're going to like this. This is kind of cool too. My fellow Melissa shared this with us. So this is a guy who had some abdominal imaging for hernia. And what's kind of cool is if we look at his aorta. So here we are at the diaphragmatic hiatus. And you'll notice once we enter the abdomen, the aorta kind of collapses flat, almost inverts here like a smiley. It's like an inverted tracheomalacia there. There's atherosclerosis. And it says this tiny little aorta, small iliac arteries that are also kind of flat. And at the time, it wasn't recognized for what it was. So they ultimately did another study using just during standard inspiration with contrast here, and we can see our aorta is normal except for the plaque. So this is a case of Valsalva causing aortic collapse, and I've never seen this before, but one of our residents or someone looked it up, and apparently there are some reports of it, particularly in elite athletes who can generate massive intra-abdominal pressure when they Valsalva. But I was kind of surprised to see this in a patient with this much intra-abdominal fat. I would figure it'd be harder, in the kind of thinner muscles, it'd be harder to generate that kind of muscle, intra-abdominal pressure. I don't know, David, have you ever seen anything like that?
No, I mean, it's amazing. You know,
I mean,
it shows, I mean, abdominal muscles are capable of generating a lot, maybe because in this case, they're kind of pre-stressed by all the abdominal fat.
mm-hmm.
So that's very impressive.
Yeah, I would think you'd have to be hypotensive because if you have normal, I mean, 120 millimeters of mercury is a lot of pressure.
Yeah.
Push against, but
yeah.
But it
So
pops
maybe
right open.
experiencing leg ischemia during his CT scan with all of that.
But you can see there's nothing wrong with the aorta at all other than some minimal plaque. So that was kind of fun. And then my last case is also something I found really odd. My colleague Daniela showed me this case. So this is a patient who had a surgery for lung cancer. You can see we have nice smoking-related emphysema with some bullae, some central lobular emphysema, and then has this sort of upper lung peripheral ground glass opacity, often associated with this emphysema. And as we go down, we see more of it in the lower lungs. Posteriorly, you see that ground glass admixed with emphysema. So we see this a lot in smokers. I suspect when I see this, it's a mix of emphysema and some smoking-related lung disease, often some mild fibrosis or even respiratory bronchiolitis, although it's more confluent. It almost reaches that DIP spectrum. And then there's a little lung cancer down there. I think there's another one on the other side, probably more indolent. But there's some discrete ground glass nodules. Anyway, and this is a hamartoma. They took out the right lower lobe and resected this lung cancer. And what's kind of strange is if we go look at the lungs now, that ground glass opacity for the most part has disappeared. And they're only about 6-7 months apart. And the only thing that happened besides the surgery was the patient quit smoking. but I've never seen smoking related, and on the path report of the lobectomy specimen, they described respiratory bronchiolitis and some mild fibrosis with emphysema. So, I mean, they described what we expected to see based on the CT, but I have never seen smoking related parenchymal lung disease clear up this quickly. I mean, most of the time it never goes away. Like RB will persist for years, decades, may not ever go away, and that's probably another cancer there. But I don't know, David, have you ever seen smoking related stuff clear so quickly?
No, I mean, I think that's dramatic. But I think it goes along with there being respiratory bronchiolitis. There's something reversible.
Mm-hmm.
And I don't know whether he was put on steroids or something like that that might help clear up the inflammation. Maybe re-expanding that right upper lung, with after the resection,
Yeah.
helped move it along. But it's probably respiratory bronchiolitis that's the reversible stuff.
Yeah, I mean, there was some fibrosis too, but clearly it went away. I've just not seen it clear that quickly because when we do tons of scans on former smokers that have respiratory bronchiolitis and they quit 20 years ago and it's still there. So I guess some people are more able to clear it out.
And maybe those people had more fibrosis developing from the chronic
Perhaps.
respiratory bronchiolitis.
Yeah, so that was kind of fun. All right, well, that is what I have. Turn it over to you, David.
Okay. I have a few cases. I hope I'm ready to share these things without unintentional revealing of any patient information here. I think I'm okay. Okay, so this person had some abnormalities detected on abdominal CT and then had this chest CT. So I don't have a plain radiograph, but I do have a scout view showing lowish lung volume reflecting abdominal obesity, and not much in the lung bases, maybe a few extra little lines. And then on a lung window, we see that there is this kind of coarse reticulation concentrated at the periphery of the bases. I don't think that a lot of it's septal. It doesn't really trigger an IPF or an NSIP kind of differential. It really looks a lot more septal than that. And then if we look at a soft tissue window, we see that there's a lot of the little flecks of bright stuff in there. So it looks like calcium sort of distributed around there. It's not the immediately subpleural stuff that we often see with dendriform pulmonary ossification. This seems to be deeper, and it's in these septal lines that we're seeing. And it really it jumps out here with a MINIP. Here we start to string these calcifications together, and it's not the it's not the distribution of dendriform pulmonary ossification that has been attributed to aspiration, which is more central around the bigger airways where the aspirate lands. This is more at the periphery. So this pattern of septal thickening and then some calcification within it really suggests amyloidosis. And this calcium would actually be in ossification. So this is, I think, septal amyloidosis. Now, we don't have a biopsy, and the person is not symptomatic from this, so there's probably not going to be an aggressive workup. He's an older guy, and he's got other problems elsewhere. So this is probably not going to get much of a workup, but I think that this is probably septal amyloidosis. The things that are good for that are the basal distribution, the fact that it doesn't seem to be in an aspiration distribution, taking it away from those dendriform pulmonary ossifications that are sometimes very dramatic, as you've shown, Jeff, attributed to aspiration. So this is kind of out of the aspiration zone. And the fact that he's not very symptomatic. Now, the workup is probably going to begin. I hope that he at least gets some serologies to check for light chains in his bloodstream and things like that that might be associated with this pattern of amyloid. So, one of the more familiar form of amyloid is the nodular stuff often accompanied again with ossification with some calcifications in it. There's the light chain stuff that Howard has described quite a bit that can have some lucencies in it too. The lucencies in the lung probably reflecting, you know, activation of macrophages and neutrophils trying to clear up the amyloid deposition, the light chain deposition in the lung, and leading to lung digestion and therefore emphysema and cysts and things like that. So the nodular form is more common, or the the form that Howard has emphasized, which can have some associated cysts and emphysema, and then this would be the septal form of amyloidosis. So I've seen it with coarse reticulation like this. That's a third pattern of amyloid to keep in mind. So right now it's presumptive, but I think it's almost certainly amyloid, just given the distribution of the accompanying calcification, actually ossification.
Yeah, I agree with you on that, David. I think that's a good point. And I wonder how many times we see this that it actually is amyloid, but I can't think of many that go to biopsy.
Right. And, you know, there's not much incentive to do it because usually if you get pulmonary amyloid, it's usually fairly indolent. It's not the sort of amyloid that's going to kill the patient. So I've seen patients sometimes with dramatic nodular disease in the bases accompanied with emphysema and cysts that go on for 15 years and stuff like that. So it tends to be a benign kind of amyloid. It's not always associated with, say, amyloid of the heart or other organs that could lead to more complications. Okay, let's see. This person presented with a plain film way back in, I think this is 2012 here, with this fine nodular abnormality. That's the way I would interpret this plain radiograph. If I look more carefully and knowing what the CT shows, I might say that actually there's some ring shadows up here. Maybe there's some holes in the lung. Maybe it's not really just nodules. And then on CT, let's get back to the CT, we see that it's really holes in the lung, sort of irregular holes, fairly thick walls to this upper lung concentration, irregularity of these holes in the lung, not the smooth, sort of uninvolved, very clean punched out cyst that you see with LAM. And this is a really great pattern for Langerhans cell histiocytosis. And I think this woman was a cigarette smoker. She has other disease. Her main disease is multiple sclerosis. So she's had a lot of head studies. They've never shown any lesions of Langerhans cell histiocytosis in her brain. So this is not a systemic form. This is probably pulmonary. And I think she was a cigarette smoker. So I think she was talked into quitting. And there are no follow-up chest radiographs on her. So I presume that her pulmonary symptoms either went away or were never very strong to begin with. But this is a dramatic case of almost certainly Langerhans cell histiocytosis, this upper lung predominant cystic abnormality with a not so clean cyst as you would see with LAM, and the sparing of the most basal parts of the lung, relative sparing. Also, these smudgy lesions are probably, you can see some of these have little air bronchiolograms. These are cuffs of inflammatory tissue around small airways. These lesions can evolve into those sorts of cavities that we saw in the upper lungs, into the cysts. So the combination of nodules and cysts is really good for Langerhans cell. With time, the nodules go away and the cysts develop, and the cysts are then permanent. With LAM, you never see a nodular phase. You just see cysts. You don't see these fuzzy nodules, these peri-airway cuffs that are part of the inflammatory distribution of this disease of Langerhans cells. Okay, so a dramatic case of Langerhans cell, courtesy of Sudhakar, who just stumbled across this case a couple of days ago. And then I have this case here of, sorry, the scout view is backwards here, lowish lung volume and pretty clear looking lungs. And let's see, I hope I have the right study up here. Oh yeah. So this guy, this is a welder, a 51-year-old welder who has pretty clear lungs on this CT scan, but he did have a lung biopsy. You can see the staple line here, and it found some DIP-like reaction in his lungs. So I think this is just a biopsy artifact at this point. I don't really see much in the way of lung disease here, but he's got the dramatic finding that Jeff has pointed out before in people who are exposed to aluminum in the form of fumes, which is what this guy, his main exposure was. And it's these very bright lymph nodes here. So aluminum, I don't know whether it's aluminum itself or aluminum causing calcification, or maybe it's even iron deposition in these mediastinal and hilar lymph nodes. Here it is on a soft tissue window. So Jeff has shown this before with people exposed to aluminum fumes and aluminum dust. So here it is with these very nice bright lymph nodes. Now in the lung biopsy, it was just lung. They did not biopsy any of these nodes. So I don't know what the mineral is in these nodes, whether it's calcium, aluminum, or iron, or some combination. But luminosis here, at least of lymph nodes.
David, on
Yeah.
the lung, yeah, I don't buy the DIP, but on the lung windows, there was some central lobular ground glass nodule. I don't know if he was a smoker, but I wonder if it was just a sampling error, and it was just actually
Well,
maybe a little RB, or it could be it could be iron-laden macrophages, and you can tease those out
right,
with a Prussian blue stain. And I've seen that. I have a case where in a welder that had see, there's some central lobular nodules there, and I wonder
right.
if it was misinterpreted as DIP or something.
Well, they said there was a DIP stuff. They also said that there was iron in macrophages. So you're right about that. So the guy's a welder. And I think you can see the airways disease here.
Mm-hmm.
Now, maybe I can minute this up here, and maybe we can sort of bring out some of that. This actually smudges it at least at 9. I think that maybe this brings it out more at 4. There's just there's too much busyness. It's
Yeah.
Frankly, I think it's this guy's better out with just the native high res. These smudgy little central lobular things, those are real.
Yeah.
And when I was scrolling through it at first, I also had that impression. And I think there are also little small airways that are thickened. We shouldn't be seeing small airways at this peripheral distribution. Here's a few more central lobular things kind of strung out, almost tree and bud, like there.
Yeah.
So you're right. There is small airways disease.
And I bet that's iron in the lymph nodes, because I don't think it's calcium. It doesn't have that. That it's too amorphous looking.
Yeah.
Even the sarcoid with calcium looks a little different, but it doesn't take as much iron to be that dense compared to aluminum. And with the welding and the iron in the macrophages, I think that pretty much solidifies that one.
Yeah, the question is, what was he welding? And I've seen a little bit of his occupational history. I think that it was mostly aluminum that he was working with. Because they kept talking about aluminum fumes rather than emphasizing the iron. So he worked for in a shipping industry, and they were probably, I can see they're having a lot of aluminum on boats and not so much iron on ordinary boats. We're not talking about commercial boats. I think we're talking about lighter weight boats. But aluminum was the thing they kept mentioning. So I'll go back and see if I can clarify exactly what what minerals he was exposed to. So when you showed aluminum cases before, did you have any notion of what the histology is of the lymph nodes?
No, I don't, because there's no reason to biopsy them. We see dense lymph nodes in people who work with silica and coal, even if they don't have visible pneumoconiosis. So it's just the lymphatics doing what they're supposed to do, and whatever dust you're inhaling that's accumulating in the lymph nodes, it depends on its atomic number, right? So, I guess it could be aluminum, but just given how dense they were and the fact they had iron in macrophages, I would think it would take less iron per unit volume than it would aluminum to see it dense on CT. But maybe it's a mix. It's probably a mix, because even if he welds with aluminum, I think most welders still weld with iron as well, or when they're training, or steel. But mean, you're vaporizing all
Sure.
sorts of metal. So,
Got it.
but I've seen
Okay,
it in
well,
people
those are
who don't
those
even, like the
cases.
aluminum cases I've seen. The one, it wasn't even a welder. It's just there's aluminum dust they're inhaling from like machining.
Uh-huh. Right.
And
Okay.
aluminum typically oxidizes pretty quickly. That kind of dull gray coating you see on like a chain link fence. So I wonder if it's the oxide um, that they're inhaling as a powder, sort of as dust particles. But either way, I think it's just a nice illustration of the lungs doing what they're supposed to do, and that's to clear out all the stuff that gets stuck in there.
And then just dump it into the nodes, poor nodes downstream.
Yeah, well, that's their job, right?
Right.
That's a nice case.
Okay.
All right. Well, we'll have a short conference today, and hopefully, I think Howard's still on his prolonged vacation, so I haven't heard from him. And Travis is, of course, starting a new job, so we'll hopefully hear from him next week. Well,
Okay.
thanks, David.
Tune in next week. Thanks, Jeff.
Talk to you later.
Bye-bye.
Bye.